Hello, my name is Naveed Sattar. I am a Professor of Metabolic Medicine in the University of Glasgow. I'm here to talk to you about hemoglobin A1c in cardiovascular disease. So, the basics for hemoglobin A1. Hemoglobin A1 is glycated hemoglobin. When hemoglobin joins with glucose, it becomes glycated. And because red cells survive for around about 8 to 12 weeks before they renew, glycated hemoglobin reflects average glucose levels for the last 2 to 3 months. And in particular, really it's the last 2 months which captures most of the hemoglobin A1 and glycemia variation. New assays for hemoglobin A1 came into force in sort of the last decade or so, and with far better quality control and international standardization, it enabled hemoglobin A1 to be recommended for diabetes diagnosis by a number of authorities throughout the world. We have 3 different choices for diagnosing diabetes. We have firstly, fasting glucose, secondly, hemoglobin A1, and thirdly, the oral glucose tolerance test, which you are all familiar with. And hemoglobin A1 actually does just as well, if not better, than the other 2 in some aspects. But the important thing is it's probably just as good, although this has been a debated point by many colleagues around the world. The new diagnostic criteria came in, as I say, around about 5 to 10 years ago. And these were that a hemoglobin A1c greater than 6.5% or 6.5% and above, or 48 millimoles per mole, was recommended as a cut point for diagnosis of diabetes. If you see a patient who has this level, you should really confirm it with a repeat test, unless, of course, they have significant symptoms or a random glucose or a fasting glucose above 11.1. A value of less than 6.5 does not exclude diabetes, that some say may be diagnosed using other glucose tests, but in reality, in clinical practice, I think it's actually best to avoid mixing different tests. If hemoglobin A1c is not available in your area, then fasting blood glucose is also recommended as a first-line test. If A1c is not possible, it probably is not possible only in a small number of circumstances if the patient has hemoglobinopathy, although in reality most assays can overcome this, or if the patient has abnormal red cell turnover, for example, in patients with advanced renal disease or severe anemia. In that case, then the use of fasting glucose is recommended. Some methodological aspects which are really relatively simple. The methodology now is so good that the standardization issue has led to very good assays, and intra-assay CVs are typically less than 5%, which is as good as many clinical chemistry methods. There are no issues in terms of sampling method. It's collected usually in an EDTA sample, and it's stable during transportation for even up to 7 days. And the day-to-day variation is actually very small. As I said, individual CVs are also very low, so it's an excellent, robust test in every respect. This shows you in the top axis, by fasting glucose, the development or the point of inflection above which retinopathy starts to develop. And here, moderate retinopathy develops around about fasting glucose, around 6.5 to 7, and the criteria is 7 millimoles for fasting glucose. This shows you for hemoglobin A1c, again, the inflection point for where the prevalence of retinopathy goes up is around about 6.5%. So that actually concurs with the diagnostic criteria. In contrast, if you look at the 2-hour glucose, it's not as easy to see a clear inflection point. Now, there are caveats to this particular analysis, but nevertheless, the top-line message for this is that hemoglobin A1c is a good demarcator of the risk of retinopathy, and in turn, development of retinopathy is what defines the diagnostic criteria for diabetes, because it's development of end organ damage, so retinopathy being that end organ damage. If you take patients with diabetes, what do we see in terms of risk for macrovascular disease or microvascular disease? Well, the bottom figure, if we go to it on the right, shows you that microvascular event risk begins above 6.5%. Now, these were data, post-hoc data from the ADVANCE study, published by Zungas and colleagues in 2012. So that concurs with the diagnostic criteria. The inflection point, or the nadir, for macrovascular disease, so heart disease and stroke, was around about 7%, and the risk goes up there afterwards. If you look at patients without diabetes, this is another area of strong controversy. Some researchers would say that post-load glucose is the best, but in fact, this is a paper that was published in 2010, and there are subsequent papers that show the same thing in meta-analysis. And if you look at the meta-analysis, if you per higher per millimole fasting glucose, the hazard ratio is 1.05. The same for post-low glucose is 1.05. But for 1% higher hemoglobin A1c, it is 1.2. So thus, hemoglobin A1c is a modest predictor of cardiovascular events in patients without known diabetes. All this information has fed into the criteria. And here I'm going to show you the ESC EASD criteria, which was published in 2013, which I was fortunate to be on the review panel. And here it was recommended that the diagnosis of diabetes is based on hemoglobin A1 and fasting glucose, and that the OGDT could be used if still in doubt. The reality is most patients in most clinical scenarios will probably be able to do hemoglobin A1c because they're probably not fasting. And whether they should have both fasting and hemoglobin A1 is also, I think, an area of controversy. But what I would say clinically, if you're going to measure one or have the opportunity to measure one, more often than not, it will be hemoglobin A1c that is measurable. So top line, in terms of risk, lowering hemoglobin A1c per se does lower risk for kidney and eye disease, i.e. microvascular disease. It does lower risk for nerve disease, but it takes several years because nerve disease or neuropathy takes many years to develop. And it does lower risk for CVD, but the effect is relatively modest. And I'm going to show you this in the next couple of slides. We've also recognized that the diabetes CVD risk is much more than glycemia. So whilst we do focus rightly on hemoglobin A1c, we also recognize that drugs that we can use in diabetes that maybe not necessarily lower hemoglobin A1c can lower cardiovascular events by mechanisms such as hemodynamic effects, effects on the vasculature, maybe lowering weight, blood pressure, and perhaps also helping the avoidance of hypoglycemia by stopping patients going on to drugs which can cause increased risk of hypoglycemia. There is a dual effect of, one, lowering hemoglobin A1c, but also targeting other risk factors, which we do, and drugs that target other risk factors beyond glycemia. As I said, lowering hemoglobin A1c has a modest effect on cardiovascular risk. In this particular paper, which we published in 2009, treating 200 patients for 5 years with glucose-lowering drugs to lower hemoglobin A1c by 0.9% prevented around about 2 events. Similarly, 1 millimole reduction in LDL prevented about 8 events, and a 4 millimeter mercury reduction about 12 events. And thus, this paper helped establish that statins and blood pressure lowering have a greater effect than glucose lowering per se on preventing cardiovascular disease. But nevertheless, lowering hemoglobin A1c does have some benefits for macrovascular disease. What about microvascular events? If you lower, in the same type of studies, lowering hemoglobin A1c by the same amount, 0.9%, lowers risk for kidney disease by 20%, eye events by 13%, but not nerve events. Now, the caveat here that these studies were only 5 years, and thus we need longer studies to truly establish this. But we do know epidemiologically that high sugar levels do increase the risk of nerve damage and neuropathy. Some specific points. Hemoglobin A1c, as I've mentioned before, can be done at any time of the day and regardless of a recent event. So if a patient has, for example, a recent myocardial infarction, when we know that the glucose result will not be accurate, hemoglobin A1c will be fine. So possible in the coronary K unit or afternoon clinics or even in the morning clinics when patients are not fasting, which is predominantly most of the time. So it's an ideal test in many cardiology patients, and an EDTA sample is what is required. Remember also now that around the world, this was perhaps firstly pushed in countries like the UK, but recent ESC guidelines, which I was involved in, have recommended that lipids can also be done non-fasting and are perfectly acceptable because cholesterol and HDL do not change appreciably, whether fasting or non-fasting, and they predict risk just as well. So in a clinic in the afternoon, one can measure non-fasting lipids and hemoglobin A1 at the same time, if that's required. If hemoglobin A1c is not above 6.5%, but is in the category in the UK certainly from 6 to 6.4%, then the patients are considered at high risk for diabetes. In the US, that range is 5.7 to 6.4%. If the patient does have a high risk, the patient should be told about it, and they should be given advice and helped in terms of lifestyle changes to prevent the onset of diabetes, whether or not they have cardiovascular disease. And losing 2 to 3 kilograms will help many patients lessen their progression towards diabetes in a meaningful way. Last few slides. Glycemic targets. A hemoglobin A1c target of less than 53 millimoles per mole or 7% is associated with decreased frequency and severity. of microvascular disease. For macrovascular disease, the target is perhaps less compelling, but nevertheless, again, a target of less than 7% for the majority is recommended, acknowledging the individual needs of the patients. So, an overall target of less than 7%, but actually, in reality, if the patient has just been diagnosed and has no real serious adverse or significant cardiovascular disease and has a long life expectancy and no other concerns, then you should aim for a level below 6.5% because they can easily cope with this and they will give them benefit. By contrast, if a patient is elderly, has long-standing disease or complicated disease, you may wish to relax the target to 7.5 to 8% in those patients. And all targets should be tried to be achieved without developing hypoglycemia or other adverse effects. But we do know that certain drugs like sulfonylureas and insulin do increase the risk of hypoglycemia, but fortunately we now have other therapies that can be used instead to delay insulin use and or lessen the risk of hypoglycemia and weight gain. So glycemic control should be individualized to each patient. It's important to think about the patient's quality of life, the effects of polypharmacy, and also the inconvenience of intensified control. The best individual compromise is between glucose control and vascular risk, and it should be looked for. The patient must be informed, educated, and understand the benefits and risks with intensified treatment. Of course, we should try and limit hypoglycemia, which increases if you try intensified treatment, and it also increases the risk of severe cardiovascular events. So in patients with cardiovascular disease, limiting drugs that can cause hypoglycemia has potential advantages to cardiovascular risk, but also to the patient's quality of life. And chronic kidney disease is also something that can affect quality of life, and there are dose adjustments for certain therapies that are required. And finally, in elderly patients, less stringent targets may be acceptable, given that the benefits in terms of life expectancy may not be there, and clearly reducing the use of drugs that cause hypoglycemia is also advantageous in elderly people. So, my last slide. Hemoglobin A1c is now accepted around the world for diagnosis of diabetes, and it can be done pretty much any time of the day and or whether the patient has had an acute event, as long as that event hasn't lasted for several weeks. It can be done in cardiology clinics and outpatient clinics and coronary care units when the patient typically is not fasted. You have to be careful in terms of measurements of hemoglobin A1c when the patient has severe chronic kidney disease, or altered red blood cell turnover or severe anemia, but these are the minority of cases. But the vast majority, hemoglobin A1c is absolutely fine. It provides a new diagnosis, and if your patient with cardiovascular disease can be diagnosed with diabetes, then that opens up the potential to treat them with new drugs which you now know lower CVD mortality. So I think that is beneficial for the patient. It can also identify patients at high risk of diabetes, and that is also important for lifestyle. Once they have diabetes, then hemoglobin A1c is the metric we use for control of dysglycemia over time, and that's what we treat targets to as well. Reducing hemoglobin A1c lowers microvascular risk, more so than macrovascular risk, but it does have a slow, modest effect on macrovascular disease per se, although not as good as lipid lowering or blood pressure lowering, which we clearly recommend initially in patients with cardiovascular disease. And finally, whilst hemoglobin A1c is a target in patients with cardiovascular disease and generally, we now know that newer drugs lower CVD well beyond their hemoglobin A1 effect. And these drugs may also lessen hypoglycemia and weight gain, and these factors may well be advantageous to our patients, particularly those with cardiovascular disease. Thank you very much.